Okay, how's everybody doing today? I hope you all are doing well. This right here is going to be your lecture for PHTLS. It's going to be your disability, your spinal trauma. You can also, we're going to be making some references in your PHTLS book that is going to be chapter 9, somewhere around page 284. Okay, so if y'all can follow along with me whenever I'm going through this as well. Thank you. Okay, so in this right here, again, this is going to be, we're going to identify some signs and symptoms that are going to be related to spinal injury versus neurogenic shock. Very important to notice the difference between standard spinal cord injury and neurogenic shock. The pathophysiology of your spinal injury and neurogenic shock as well, the patho behind it. We're going to also have some evidence-based stuff related to the care of spinal injury, such as spinal motion restriction, when and when not to. And then, of course, we're going to also talk about and identify indications for the spinal motion restriction, which your book is going to cover as well. And we make a reference to that just momentarily. And also, we're going to talk about the appropriate pain management interventions for these patients also that are dealing with spinal motion restriction as far as spinal cord injuries. Okay, so we're going to begin this lecture off with your presentation of your dispatch. Okay, so this is what we got right here, guys. So y'all can see that. If y'all can see it over there, you can actually see the swimming pool there. So you know we're going to be dealing with this. You're going to have yourself a warm, sunny afternoon. Temperature's about 82 degrees outside, so which looks pretty good. Okay, your dispatch information is going to be a 24-year-old male. The patient is unable to move his arms or his legs after diving. Okay, so he can't move his arms or his legs. His head first into the backboard of the pool. So went head first in the backyard of the pool. Okay, patient has been removed from the pool by bystanders. So they did pull him from the pool. So he has now been removed from the water. Correct. He's now laying on the side of the pool. And again, let's just repeat this again, but you guys can see that the patient is unable to move his arms or his legs after diving head first into the backyard pool. Now, so you're going to ask yourself this right here. What are your concerns about the scene? So let's talk about first, what are some of your concerns that you think may be about the scene that itself? Okay? What are your concerns about the patient? Do you suspect any type of traumatic spinal injury with this? Should manual stabilization be performed? So let's talk a little bit right here about this. So let's think about it. The incident itself, it involves possibly a near drowning, right? Because he dived into the water, correct? Could you potentially have a traumatic brain injury? As we talked about in the last lecture about traumatic brain injuries that often come associated with trauma, right? 10% of those come from trauma. And of course, standard spinal cord injuries that can be associated with it. So, now you have to ask yourself these questions here. Is my scene, do I have any safety issues? Are there people, since you're in a backyard, a pool, 22-year-old, a lot of friends? Could it possibly be intoxicated friends? There may be a lot of people that may be panicking, maybe a girlfriend, correct? Could be a father or a mother, brother or a sister, aunt or an uncle that's sitting there going, oh, he can't move his arms or he can't move his legs. And now then you also think you have a lot of slippery surfaces around the pool. People are running around, doing everything else. You got to actually ask yourself, is the scene safe enough for me? So then you got to say, okay, now you're going to talk to people about, when you look at your assessment of the scene, what do you see? Do you see anything that may be potential hazards for yourself as well? Are there any signs like alcohol, drug use, drug paraphernalia in the area that you may have to deal with by calling the police out or something like that? You also have to think about, when the patient struck his head, what did he strike his head on? Did he strike his head? Did he do like a backflip? Did he dive off the backboard and hit it? What, did he dive face first into the pool and hit the shallow end? So you got to find out through your investigations of doing your sample history and everything else, is that what exactly happened? Did he hit his head? Did he not hit his head? Did he go down the bottom of the pool? Did not come up? Did y'all have to pull him out? Did you have to wind up doing any resuscitation to him, such as if you talk to them, say, did y'all have to revive him in any way? Was he unconscious? Did you have to push water out of his mouth? Whatever else it may be. So there's a lot of concerns here. You know, again, like I say, pulling from the pool. Also, even though it's 78 degrees that's outside, is there a chance of hypothermia? Because is the factors at the pool, is there a problem with, is the swimming pool, is it warm? Is it not warm? Is it cold? So you have to think about the patient, is the patient hypothermic? So, and when you think about, with your suspected for your actual with your traumatic spinal cord injury. On this patient right here, you're going to notice here in a few minutes that he does have an abrasion on his forehead, so we know that he did hit his head. We'll look at that again in a minute, okay? And so therefore, does that mean he possibly hit his head on the bottom of the pool, right? Small abrasion comes from concrete, bottom of a pool, you know, different type of the pool that it is. And the fact that he's not moving his arms or his legs may indicate that you got a major problem going on with him, such as a significant spinal cord injury. Okay, his pulse rate may be potentially fast. We'll see that in a few minutes. So you ask yourself, should you manage the C-spine? Well, we know that's an obvious. We're going to actually maintain C-spine on the patient. We're not going to let it go, okay, because we obviously know we're dealing with a spinal cord injury of some kind and also a potential traumatic brain injury, a TBI, because you have to think about if he remains conscious or not. So we got to look at that in the processes as well. It's a building block with PHTLS sometimes. And so therefore, is he alert? Is he oriented times 3, AO times 4? Is he confused? Is he potentially going to get worse? Could he have it, like I say, could he have a traumatic brain injury that could be potentially involved? Do I need to look for other signs and symptoms, posturing, whatever else it may be? A lot of things are involved while you're still trying to look at what is the cause of what was the thing that caused it, what happened to him, what other type of things may be associated with this injury itself, from primary injury to secondary injuries. Okay, so let's go ahead and look at our scene size up here. All right, so looking at the scene size up, the scene appears to be safe at this time, and what we're looking at, you got a group of friends, they're being very cooperative with you, so let's get the picture here if we can. Right, there's a decking, and it's a non-slip surface that's around the pool. So you got that picture? Okay, also, they report that he dove, so listen to this one here now. They report that he dove into the pool and did not come up. So now what are we dealing with? Possible near drowning, which means he hit the bottom of the pool. Did he take on any water? The question we have to ask ourselves is it a saltwater pool, a freshwater pool? Right? That often makes a difference in the care of the patient if they have a lot of water coming out of their mouth or whatever else it may be. But that's for another lecture at a different time. Also, you have bystanders that pulled him from the pool. They laid him out on the side of the deck. Okay, so they just drug him from the pool, laid him out on the side of the deck, which means was his C-spine maintained? Unless they were medically trained, probably not. All right, then, so now we got ourselves our general impression that we've got. All right, so we got the patient. He's lying supine on the side of the pool, but he's not moving. He is, but, however, it's not that he can't feel anything. He is complaining of neck pain. So in some ways, when you think about it, that's probably a pretty good sign for some things, because he does actually feel pain in his neck, even though his arms and his legs cannot move at this time. Okay, so that's a good sign there. We're going to go back here to the examination part right here. Under X, there is no severe external bleeding that has been found. Okay, his airway is currently open and patent. He does have fast, normal chest rise and fall, which is good, not abnormal, no abnormal breathing, associated signs of a head injury at this time. However, look at what we're dealing with. We do have a slow, not fast, which should be rapid. Would y'all not agree? Think about it. So it should be a fast pulse rate, especially where he dove into the pool and everything's been going on, all the excitement of the scene, and everything is happening. He should have a fast pulse. That should start putting something in the back of your mind. Is there something wrong with what is going on with this patient? But his pulse is thready. Slow but thready, which means, are we going to have a normal blood pressure, or are we going to have a low blood pressure? That's what we have to think about now. Low blood pressure or normal blood pressure? When you think about it, a thready pulse indicates what? Yeah, that's right. It indicates the factors that you do have a patient who may be potentially hypotensive. However, does this make sense to you? The slow, thready pulse, right, shows signs of hypotensive, but yet his skin is warm, pink and warm. That should be pale, cool, and clammy. His Glasgow coma score is 10, so obviously we do have some confusion there because it's not 15, correct? He's got an eye-opening response of 4, he has a voice response of 5, and a motor response of 1. Okay. He has a minor abrasion of the forehead, so in your mind you're starting to think, he hit his head where? On the bottom of the pool? Was it in the shallow end because he took a long dive? Was it in the deep end? We do not know. And at this point, it doesn't really make that big of a difference as to where it's at. We just know that he did hit his head on the bottom of the pool. So now then, look at some causes right here of our spinal cord injuries. Very, very interesting. Motor vehicles, they actually attribute to about 48% of all causes of spinal cord injuries. Falls are 21%. Remember we talked about earlier in the TBI lecture, we talked about the factors of falls being like 10% of what's going on with the pediatric patients as well with their injuries. Penetrating injuries about 15% for spinal cord injuries, right? Sports injuries about 14%, which would be like football, right, baseball, hockey, whatever else it may be. And then of course others 2%, which is going to be your incidentals of maybe, falling off a ladder or something like that. Spinal cord injuries can also be very life-threatening because why? When we're looking at this right here, we're saying, okay, what is severity? Okay, what part of the cord has been affected? Okay, is it somewhere high up in the cervical spine? Is it going to be somewhere within the thorax, right, chest wall cavity, or somewhere in the lower part of the thorax down towards the abdominal section? Correct. So all those things you got to think about. And then you have to say what nearby structures have been damaged, what things have happened to these areas. So you got a broken arm, whatever else it may be. If you have a head injury associated with it, with the abrasion on the head, such as what this one is right here. Because when you're thinking about it, think about with a spinal cord injury, right? With things that could be implicating long-term disabilities, right? They're often associated with a high energy force, such as this dive off the diving board itself, versus a low energy type thing, which often comes from much like older adults, like a elderly person may just fall out of a chair and hit the floor or something like that, or on the toilet, going to the bathroom and they go to stand up and they slip and fall and hit the floor. Remember that the skeletal structure, and we're going to watch a video here in a little while that talks about the entire skeletal structure of the body as well, of the spine. It may not result in damage to the spinal cord, but it may actually damage the vessels, the nerves around it, whatever else it may be. But it may actually cause an injury without fracture or dislocation to the actual vertebrae itself. So you can actually have a spinal cord damage, but the vertebrae itself can still be intact. However, you may also have damaged the bony structures, the ligaments that may support it, the column, everything else, but yet you do not have any problem with the cord. But you still have to have the spinal motion restriction related to both the bony prominences of the spinal column and also, of course, the actual nerve endings themselves and, of course, the spinal cord itself. And, of course, you have to think about, did the patient sustain an injury that is irreparably irreversible, correct, that may leave the patient with a lifelong neurological disability? A lot of things is involved. And so when we're thinking about this right here, a lot of people say, oh, we got to put them on the backboard, spinal immobilize them, or whatever else it may be. This is the most critical part when you're dealing with a patient who you're going to be immobilizing. Because if you don't properly take the steps and follow the procedures to limit injury to the spinal cord, you can actually further the damage and cause even more. And that brings it to factors of someone who, say, is in a car and people no longer use the Kendrick's extrication device to get them out of a car. They actually just wind up saying, okay, sir, we've got the seat collar on you, turn around, stand up, get on the backboard. That's no different than having this guy who fell out of a pool. Hey, sir, would you mind doing me a favor? Can you try to help us slide you over to a backboard? It's no difference. There's this point right here where it comes to the factors of what we're supposed to render as care and aid for this patient. And when they have a potential spinal cord injury, they may have a lifelong injury that occurs because we did something wrong. We put the improper size seat collar on them. We improperly moved them by not taking the patient down and moving them up, but we slid them laterally sideways on the backboard because they were large and obese, or whatever else it may be, or because we didn't properly do it, we were in a hurry trying to get them off the scene. And I know we're not talking about life over limb. We're just talking about the factors of we just don't want to be careless with patients with neck and back injuries. Okay? All right, so from here, right now, we're gonna pause right here, and we're gonna actually watch a video specifically about the cervical spinal anatomy, and we're gonna let y'all watch that here for a few minutes, and then we're gonna come back and we're gonna continue on with the lecture. Okay, so we'll see you back here momentarily.